All right, I'm bummed I don't get to see you right now because I love this topic. We're going to be talking about community nutrition focused on maternal and infant health. And to give you sort of a quick overview, my goals for your learning for this unit are to have a sense of what the trends are in terms of breastfeeding and maternal mortality and infant mortality, identify some of the barriers and benefits to breastfeeding, and then we'll kind of dig into some of those like policy approaches, because again, policy is a really important part of community nutrition. And then have a little bit of content related to WIC. Again, I know many of you have learned about WIC, or if you've at least heard of it. This is our opportunity to go in a little bit deeper and think about, what is the program offering? What are the eligibility requirements, and what impact is WIC having on the community? All right, so for this unit, I'm going to be talking for this video, I'm going to be talking about health trends. So I want you to have a general sense of what we're seeing in terms of changes. So we're going to start with talking about infant mortality rate. And this is something that's used sort of as a metric for overall population health. So it's not just actually focused on babies, although of course that is the measurement, but it's used by the World Health Organization and other global entities to determine how well developed a nation's healthcare system is, and how equitable access to food and resources is in a nation. And so we measure infant mortality by the number of infant deaths per 1,000 live births. So a baby has to have been born alive to be counted. So if a baby is stillborn, they're not included. That's a different rate. And these are basically looking at the survival rate once a child has been born. So you can see here in this graph, unfortunately, the United States has the highest infant mortality rate of any industrialized nation, which is similar to, when we look at healthcare, right? We spend the most on healthcare, but we have a ton of chronic disease. Like, there are things in the United States that have gone well, but when it comes to healthcare, and especially addressing health issues that have a lot of connection to like systemic poverty or barriers to care, we don't do as well as other countries do. Some would argue it's because we're very diverse and we have a lot of challenges in our nation trying to reach lots of different kinds of people. Places like Belgium, where 90% of people are Belgian. Culturally, it's pretty easy, and then there's just less to think about. But we do have a lot of financial resources, and I think this is an area where, as a nation, I hope will continue to grow. You can see Japan actually has the lowest infant mortality rate, only 2.1, compared to our 5.8. Which might not seem like that much per 1,000 live births, but if you think about, we have millions and millions of babies that are born, that adds up, and it's quite a lot of babies annually. Is really assumed to be something that is mostly preventable. There are always going to be some infants for congenital reasons, genetic reasons, that they weren't going to survive, but most should be able to. So when we think about what contributes to infant mortality, it's really looking at the outside ring of that social ecological model. So thinking about all the policies and the resources and the community structures. So poverty, if people don't have good access to health care, right? So in other nations where there's no prenatal care, there's no hospitals, infant mortality is high. People don't have access to good nutrition during pregnancy, their babies are less likely to survive. But then also postnatally, after a baby is born, if they don't have access to clean water, to enough nutrition to support breastfeeding or formula feeding, then an infant is less likely to survive as well. So we look at a lot of those barriers. And then we look at the individual level for individual choices that mothers make. We see things like, obviously alcohol or substance abuse is going to impact infant mortality. So exposure to alcohol or drugs in utero is of course not good for a baby. We also see that things like folate intake, if a woman isn't having enough nutrition, especially in those early weeks when like the neuro 2 development is happening, then that could also lead to life-threatening congenital problems when a child is born. Unfortunately, as we know, there are a lot of health disparities by race, ethnicity in the United States. Some of these might have to do with culture, but most of them have to do with poverty, access, and then on some level there is some systemic racism that exists in healthcare settings, which we've learned about and you've seen in this class, and then especially I think in cultural nutrition. So you can see here the Asians have the lowest rate of infant mortality, um, and white and Hispanic Latinx infants also have a fairly low mortality by comparison. But when we think our national, average, is supposed to be about 6, when we look at Black or African American babies, it's almost double that. And this is older data, so you can see it's 2000 and 2013, so it's gone down. It's gone down a little bit in recent years, but not that much. And again, access to healthcare is a big part of this. So as we see people losing access to healthcare with some of the administrative, the Trump administration's decisions about reducing access to the Affordable Care Act, healthcare insurance pools, and we have the coronavirus now, so people are losing their jobs and thus losing their health insurance, we're definitely going to see something like infant mortality go up unless people get access to social safety net services like WIC, which we'll talk about. Maternal mortality, again, is also looking at, it's a marker that we can use to look at the overall wellness and access to healthcare of a nation. So the reasons women die during childbirth, some of them are totally preventable. A big part of it is prenatal care. So if any of you have ever had babies, you know that you have to go in pretty regularly. You have to pee in a cup. They're checking, protein in your urine. They're checking your blood pressure to see if you're starting to develop, preeclampsia or any other like life-threatening conditions that could be contributing to poor outcomes for you. Gestational diabetes would be another one. If a woman isn't gaining enough weight or she's gaining too much weight, that can impact her her survival rate, because if she gains too much, there's more likely to be complications in delivery. And overweight or obese women are more likely to have complications delivering, or are more likely to have cesarean deliveries, which can increase complication risks because it is still a major surgery. And then social support. So people like pregnant teens or single moms are higher or more at risk of maternal mortality because they may not have people helping take care of them even when they're home from the hospital. And that maternal mortality is within, I think it's the first, I want to say month or 2 months of after delivery has happened. So there's kind of this window, and a lot of women don't always die right during childbirth, but they might die within the days or weeks after, especially if they don't have access to good health care. They might get, have some symptoms. They might have bleeding or something else happening, and it doesn't get caught, and then they pass away from this. And then other systemic barriers as well is, just access to the quality of healthcare that you have in a hospital. Do you have a hospital where somebody gives you a lot of education? They call you up, you have nurses that are coming in and checking on you, things like that. So I wanted to have this go a little bit more local. So I wanted to look at mortality rates in LA County. So again, maternal mortality is different from infant mortality in that we measure it by deaths per 100,000 live births. So infant mortality is per 1,000 live births. But for maternal mortality, it's 100,000 because it's obviously a lot lower than infant mortality because infants also die for other reasons. So in Los Angeles County, Asian or Pacific Islander moms, we see fewer than 5 per 100,000 live births. When we look at white moms, we see fewer than 5, so seems fairly low. And when we look at Hispanic, more than double. So again, right there, we know that when we think about what contributes to maternal mortality, we think about like access to care, nutrition, things like that. And then when we look at Black or African American moms, it's 86. I mean, it's like a startling and totally unacceptable number. I hope that takes your breath away when you see that. When we look at what the Healthy People 2020 target is, it's 11. So overall, as a county, if you're white or Asian, we're actually doing very well. We're not doing as well for, mothers of color. And again, I go back to this over and over and over. Access to good health care, poverty, culturally appropriate resources, and truly systemic racism in healthcare. African American women are less likely to be taken seriously when they complain of pain. They're less likely to have pain administered to them during surgical procedures. They're less likely to get pain medicine going home after labor and delivery. And they're more likely to deliver in hospitals with more overcrowding, less, attention to care. And maternal mortality is really important to me personally because I nearly died when I was giving birth to my daughter. And I had something called a pulmonary embolism, which is where I have a blood clotting disorder, and I got blood clots in my lungs during labor. And I felt really bad. Of course, I would just given birth. I was tired. And I remember telling the doctors and the nurses, something's wrong. I don't feel well. And even for me, I was, I'm white, I'm educated, I'm pretty assertive. No, 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 you're fine. It was just I had a rough labor. It was 36 hours. It was rough. So you're just tired. And they sent me home, and I was having, chest pain, and I was having a hard time breathing. And then this is a few days I'd been home, and I actually had a dream while I was napping. And in my dream, it was basically said, like, breathe, wake up, you're going to die if you don't wake up. And I woke up from this nap, like, like taking this deep breath, and I just felt off. I couldn't describe it. Something was wrong. And I called my OB, and he was like, oh, I mean, if you're really that worried about it, I guess you could go to the hospital. And I'm like, oh my gosh, no wonder maternal care is just not as good in the United States as it is in other nations. So I went to the hospital. They put me in a CT, or they scanned my my lungs, and I had tons of blood clots. And I had a doctor tell me I was like a nap away from not waking up. And thank God, my husband took me to the hospital. I had family that could watch my daughter because I was so resistant. I was so like, I'm going to breastfeed my daughter. I cannot go in the emergency room. I cannot be hospitalized. I almost didn't even go in because I didn't want to have to take a newborn into, she was like 3 days old, I think. I didn't want to have to go into the emergency room. So I'm just sharing this as my own personal story that I came very, very close to losing my own life, through just not attentive medical care. And I was at a fine hospital. Yelp said my OB/GYN was pretty good. And that was my experience. And so if you imagine people in neighborhoods and communities where there isn't the literacy, there isn't the access to social support and family and education, all these other things, this really does take people's lives. So, downer, I know. So let's move into what can we do about this. We know breastfeeding is good for babies and moms. So when we think about trying to promote infant survival, exclusive breastfeeding is where it's at. And that means nothing by mouth, no gripe water, no formula, nothing except breast milk, vitamins, or medication. And a lot of breastfed babies will be put on vitamin D drops in case their moms, because most American women are vitamin D deficient. And so that's what exclusive breastfeeding means. And some breastfeeding is better than none. So if a baby gets a little bit of breast milk and formula, that's still better than not having any. But this is the recommendation for a minimum of the first 6 months of life. So you can see here in terms of trends, in the United States, this graph is showing from the early 2000s to like the 2000 teens, we've seen a slow but steady increase in any breastfeeding. So this is ever breastfeeding. When you see landline, that just means how they found participants. They were doing like phone calls. At 6 months, you can see any breastfeeding. So again, this might mean some breast, some formula, about 40%. And then at 12 months, it's much lower. So doing any kind of breastfeeding. When you look over on the right column, exclusive breastfeeding, which is what I had mentioned before, which is the recommendation, only 30% of babies are exclusively breastfed at all. And fewer than 10%, well, actually, it's gone up a little bit. It's almost 20% now, are breastfed all the way through that 6-month mark. And we're going to talk about that in the next video, why that is. When we look at differences in race ethnicity, I think it's interesting to show that there are a couple of trends. One, we see some positive cultural connections here. So Mexican American women are significantly more likely to breastfeed than many other women from racial ethnic backgrounds. And this has to do with that strong social support that I talked about. If your mother breastfed, you're more likely to breastfeed. And so that there's also less of a Latina